Good morning. Today we're going to discuss evidence-based practices for hospice patients from a hospice nurse perspective. Hospice care is a program designed to give compassionate care to patients and families in the final phase of a terminal illness. Its main focus is on comfort and not a cure. Most of the services are offered in the home, but they do have services. They do offer services in hospitals, freestanding facilities, and nursing homes as well. Hospice care is a team approach. It consists of medical doctors, home health aides, nurses, speech therapists, pastoral care, social workers, and other entities in the medical field. So let's jump into a case study. Today we have Mrs. H, a 75-year-old female, recently brought to the hospital. She was diagnosed with cancer in 2016, which is now stage 4. Recent MRI images shows mets to the brain, and that's March of 2017. She has a history of hypertension, CAD. She's home oxygen dependent. She has a history of COPD. She has a history of tobacco use, as well as a history of a stroke. Recent tests show that she also has a pH of 7.10, PCO2 of 81.0, PO2 of 112. She's sat at 85% on a full face BiPAP. Her white blood cell count is 22,000. Hemoglobin 4.2, hematocrit 22.1. She's breathing at a rate of 38. Her BUN is 32. Creatinine is 3.28, and her heart rate is 124 sustained. Based on these lab values, it's clear that she's not only in respiratory failure, she's extremely acidotic with a pH of 7.10, but she's also in renal failure. Her BUN is 32, creatinine is 3.28, as well as heart failure. Her heart rate is 124 sustained. So after a review of the current test results, the the medical team decides that it's time to have a family conference with the patient's family. We need to discuss plan of care goals. We also know that she does have stage 4 lung cancer, which is terminal. There is no cure for that. The next step up for Mrs. H at this point will be intubation. So we need to be clear on where we're trying to go with her care. So after a meeting with the family, the oldest child, who is also the medical power of attorney, agrees to make her a DNR. So now we have a do not resuscitate order signed, and on the chart, she also agrees that she does not want her mother to succumb to any other invasive tests or procedures. She wants no more interventions, medical interventions, and she does not want an escalation of care. Her main priority right now is to make her mother as comfortable as possible. So she agrees to initiate whatever medications are needed to make this transition or this phase as comfortable as possible for her mother. So as a result, the medical team orders morphine. They order a morphine drip as well as other medications that can help aid or to help aid with comfort for Mrs. H, such as Robenal, which will help with secretions. They also order for us to discontinue monitoring her, for example, doing vital signs monitoring, so the family is not disturbed by alarms and things that are currently going off in the room. He orders a discontinuation of labs, and then he orders a case management consult, pastoral care consult, palliative care consult, and hospice care consult. So the question is, does Mrs. H meet the requirements of hospice care? If so, what makes her an ideal hospice care patient or candidate? The answer is yes. Mrs. H is an ideal hospice care patient. People who are unlikely to recover from a terminal illness is the perfect candidate for hospice care.
Hello, I'm Joshua Freitas, and I will be concluding our hospice presentation here. So we know Miss H was discharged from the hospital to go to hospice home care to finish her last hours or last days here. We know she's unresponsive, agonally breathing, showing signs of discomfort, and will be passing very soon. So nursing interventions, basically, we're going to keep her comfortable. We're not going to be doing blood pressure checks. We're maybe just checking pulse, watching breathing. Family doesn't want all that. So we're going to keep her O2 therapy with maybe up to like a non-rebreather just for comfort, as long with morphine IV, 2 milligrams every hour, just to make sure that she's comfortable. Some questions that people will have is, what spiritually can I do for my family member at home while they pass, and how will I get them to the morgue at that point? So we know that every chaplain or every hospice has a chaplain that they can have come out and talk to you, or you can use your own provider if you need to. And the funeral home is going to be assisting with bringing transporting the body to the facility in that case after you do what you need to do. Some people like to clean up. And something to consider is hospice is not only for people who are actively dying. This is something that you can do in the beginnings of the chronic illness. If you have a terminal chronic illness, you can do hospice immediately, and they'll sit down, and it's not just about dying, it's just about things to get ready for when this time comes, and they prepare you for the event. And it's better to get in, and people don't really realize that. So thank you for watching, and have a good day.
Hi, my name is Denise Akins. I know Tamika touched on the introduction of hospice and went over some orders. I'm going to go over the patient's baseline. So this is what the patient looked like before she was admitted to hospice. So just a bit of history. Miss H, of course, is a 75-year-old African-American female who was admitted in January of 2016 for some wheezing, chronic cough, hemolysis, coughing up blood for about 3 months. Upon that admission, they did a CT scan, which did reveal a mass in her right lower lobe, which later proceeded in her having a bronchoscopy with biopsy. So Mr. H was diagnosed with non-small cell lung cancer, and she is currently on a chemotherapy agent. So she presents to the ED this admission, complaining of some altered mental status, headache, nausea, and vomiting, and she's very short of breath. So as far as her history, I know Tamika touched up on the history, but she has hypertension, CAD. She's O2 dependent on 3 liters. She did smoke tobacco. She has a history of a stroke, and also she has a family history. We know that her father died of lung cancer at the age of 80. Also, here's some baseline information as far as the labs when she came into the hospital, which Tamika already went over. So we know these ABGs are abnormal. So it looks like the patient is in some type of respiratory distress. So initially, when the physician sees her in the emergency department, he's saying he wants to admit her to ICU on a continuous BiPAP. He's going to continue her home medications for blood pressure control because her blood pressure is elevated 190/85. He's going to consult neurology and obtain an MRI for the altered mental status. She has some Zofran as needed for the nausea and vomiting. Hematology and oncology will be consulted to address her chemotherapy agent that she does outpatient. We want to start that in-house as well. And as you can see, her hemoglobin is 4.2. So we're going to give her 2 units of packed red blood cell stat. So stage 1. Stage 1 is what the patient looked like when she came in. So I'm just going to reiterate. She came in with some altered mental status, headache, nausea, vomiting, shortness of breath. She does have the cancer. She's going to go straight from the ED to the ICU on a full BiPAP for respiratory distress. So assessment-wise, the patient is alert to self, which means she can tell us her name and date of birth. She's able to communicate, but she's not aware of the time. She's not aware of the situation. She doesn't remember how she even got to the hospital. So she complains of, but she does say she has a headache that radiates to her lower neck. Of course, we can see by her ABGs and her respiratory effort that she's very short of breath. She's using her accessory muscles to breathe, and she does have some diminished breath sounds that can be heard during auscultation. And then she has the nausea and vomiting, but there are bowel sounds. The abdomen is soft, non-distended, and there's no change in her bowel habits. So here are some nursing interventions for this assessment. So first off, we're going to monitor her respiratory rate, her depth and ease of respirations. We're going to monitor the client's behavior and mental status. And then we're going to monitor her oxygen saturation continuously with a pulse oximetry. We know that when the oxygen level drops, patients can become very confused, and this can also contribute to that altered mental status that she's already contributing. So here are the questions for stage 1. So the first question is, based on the patient's past medical history, what risk factors contributed to the development of lung cancer? So just by looking at this picture, there's already a list. You can see the risk factors for lung cancer. First of all, the odds. Men have a 1 in 13 chance of developing lung cancer, and women have a 1 in 16. And then we have genetics. Family history plays a huge role. And then if someone is a heavy smoker, that also contributes to their chances of developing lung cancer. And then the second question is, why do you think the physician ordered an MRI? So let's go to our answers. So the first one is Miss H. She has a family history with her father dying of lung cancer. She has smoked tobacco, and her age. These are the leading risk factors for Miss H for developing lung cancer. And the physician ordered an MRI because it uses magnetic fields, not X-rays, to produce detailed images of the body. It's also performed to help diagnose spinal cord injuries. It's to diagnose strokes, any brain injury or trauma, or even tumors. So when patients come in and they're complaining of these severe headaches, this altered mental status, nausea and vomiting, we're thinking there's something going wrong with their head. So we need to perform a test that allows us to look at the brain. And an MRI and a CT scan of the head are the best choices. So stage 2. So we got our MRI. So basically our MRI read that there's no evidence of a bleed or stroke, but there is presence of a 4 by 6 centimeter mass in her right frontoparietal area of the brain. So for stage 2, we know that the MRI results showed some metastasis of the brain. The cancer has spread from the lungs to the brain. So Miss H is still in the ICU, but she continues to deteriorate. So her eldest son, who is her power of attorney, he does not want any further medical interventions. So basically we sign a DNR, which is a do not resuscitate order. It's signed and placed on the chart, and the family is requesting a discharge home with hospice. So here are some nursing interventions. First, we're going to call the physician, and we need that consult order for case management at hospice, because case management is going to make sure we have the financial resources to get hospice started. We're going to refer family members for spiritual counseling. Research has consistently reported that spiritual support is an important factor for someone who has lost a loved one. And then we're going to assess for pain and respond appropriate measures for pain relief. Okay, so yes, the patient does not want any further medical interventions, which means they may not want the BiPAP, they may not want the blood pressure medications, but no one wants to be in pain. So the key of hospice and palliative care is comfort. So we're going to make sure that Ms. H is very comfortable. She's not moaning, she's not groaning, she's not agitated. So here's some questions for stage 2. What is the pathophysiology of metastatic brain tumors, and what are evidence-based practice guidelines for palliative care in end-of-life care decisions? So we know that brain metastasis is a secondary brain tumor. It refers to cancer that has spread from elsewhere in the body and goes to the brain. So this brain tumor is usually found when a patient complains of neurological symptoms, and only a CT or MRI can detect those things going on with the brain. And then as nurses, the best guidelines that I could find, they came from the National Guideline Clearinghouse. These objectives were to offer evidence-based recommendations for adult patients with brain tumors, and they were developed by the American Association of Neuroscience Nurses, which is a professional association. So these guidelines are very reputable. It came from a reputable source, and it says that nurses should educate patients and families about the dying process and the role of palliative care. Sometimes people don't know what hospice is. They think you're putting their loved ones in this place and they're just going to die. They don't know that people can live for years and be in hospice. It's all about comfort. We want to make sure the family's comfortable. We want to make sure the patient's comfortable. And then you also want to get palliative care early in the disease process and not wait later, because that's the best thing for patients who have these malignant brain tumors. Thank you.